Thank you for inviting me to give a Bradford Hill Seminar. I've long been a fan of Professor Hill's work in epidemiology, causal inference and clinical trials, and it's an honour to be asked to give a seminar in his name. My subject today is the future of cancer screening, stratified, pan, both or neither. I have the following disclosures to make. I'm a member of the Grail Scientific Advisory Board, but I don't have any shares with them. I will first discuss some limitations of cancer screening today and briefly talk about the exciting development in esophageal cancer screening developed here in Cambridge. I will then discuss the possibility of using polygenic risk scores or PRS in cancer screening. Next, I will discuss risk-stratified screening more generally. And the final topic of my talk will be multi-cancer early detection tests in screening and the NHS Gallery trial in particular. And I'll end with a few concluding thoughts. Cancer screening today, despite great advances in cancer treatment over the last 2 decades, cancer remains one of the most important causes of death in this country and throughout the world. For all types of cancer, survival after early stage diagnosis is substantially better than after a late stage diagnosis. But unfortunately, nearly half of cancers are diagnosed at a late stage. And for some cancers like lung cancer, that's nearly 3/4 of cancer are diagnosed at a late stage when the survival, 5-year survival is only 5%. So we really need to be able to do things to move the diagnosis of cancer from late stage to early stage if we're going to have a major impact in reducing cancer mortality. For many scientists, these sobering statistics suggest that we need new and better screening programs to find cancer early. But currently, only 83% of cancer deaths are from cancers at sites which the NHS has a screening program, so breast, bowel, or cervix. So even if we perfected breast and bowel screening, we had much better uptake, the screenings were much better, and we eliminated cervical cancer completely with HPV vaccination, we're still not going to have a major impact on cancer mortality across the population as a whole. So what we need is some new screening programs which are going to cover far more cancers. So what's on the horizon? Well, there's a targeted lung health checks is the NHS's answer to lung cancer screening. There's a pilot programs are taking place in 14 CCGs, and I anticipate that there's going to be an announcement from the UK National Screening Committee later this year in terms of whether or not there will be a rollout with a national screening program, and I anticipate that there will be. Low-dose CTs are only offered to those at the highest risk based on primarily on their smoking history. And this makes the program much more efficient. It means that we're not exposing the whole population to radiation from a CT scan, but it also means that over half of the current lung cancer deaths are in people who would not be eligible for the screening program. So there are advantages and disadvantages of targeting screening. There is currently no prostate cancer screening program in the UK, although you can get a PSA test on demand, as it were. And the reason is because although screening with PSA testing has been shown to reduce prostate cancer mortality, the harms of overdiagnosis seem to be too great to justify population screening. But advances in MRI mean that many are now interested in triaging men with low levels of PSA on screening with an MRI scan. Well, so low, but not very low. Highish, I guess. This together with a focus on reducing the harms associated with biopsies and management of early cancers makes new screening protocols worth evaluating. And I'm optimistic that there will be a new trial in prostate cancer screening funded over the next 12 months or so. Oesophageal adenocarcinoma is an aggressive cancer that has become far more common in the UK in my lifetime. Because it has a precursor lesion, Barrett's esophagus, the hope is that screening could not just reduce mortality from this cancer, but prevent it altogether. In a similar way as cervical screening, which finds cervical precancers, CIN, and those are treated, and cervical cancer is prevented. So Professor Fitzgerald invented a cytosponge, which is a sponge on a thread. The sponge is compressed and stored in a gelatin capsule, which is about the same size as an antibiotic capsule. The patient swallows the capsule with a glass of water, whilst a nurse holds on to the other end of the thread. After a few minutes to allow for the gelatin to dissolve, the expanded sponge is retrieved and it collects cells as it passes through the esophagus and it's pulled out. I was going to have this just before COVID struck because I felt I shouldn't be talking about it if I didn't know what it was actually like, but unfortunately I haven't yet done that. But the vast majority of patients say they prefer to have this than an endoscopy, and that they would be willing to have another test. So I think it sounds worse than it is. We did a large case control study, BEST2, in individuals intending for endoscopy, and the per protocol sensitivity to Barrett's esophagus of the test was 80%. But if samples with no gastric cells were called inadequate, the sensitivity amongst the remaining samples was 94%. And in future trials, we have always said that if there's no gastric cells in the sample, that's an inadequate sample, and the individuals have been asked to come back for a second cytosponge examination. The sensitivity and specificity from BEST2, so that was this 94% in those who actually have gastric cells. The results from BEST2 led us to do a large trial, BEST3, which was a randomized controlled trial targeting people who had reflux symptoms, and they were mostly on proton pump inhibitors. And it was trying to find Barrett's esophagus in those high-risk individuals. There was a randomization and Zellin design effectively, so the people in the control arm didn't have any particular intervention. And about a quarter of those who were offered a cytosponge exam actually came forward. But despite that, we found 10 times as much Barrett's esophagus in the intervention arm compared to the usual care arm. And even more exciting was that there were 9 patients with dysplastic Barrett's or intramucosal cancer in the intervention arm and none in the control arm. And it's likely that probably something like 7 of those 9 patients would have died from esophageal cancer had they not taken part in the trial. And we're very optimistic that all 9 of them will have been cured of their cancer or precancer. And 2 weeks ago, Cancer Research UK and the NIHR announced that they will be jointly funding BEST4, which will include a randomized controlled trial powered to see if targeted screening with the cytosponge TFF3 test can reduce mortality from esophageal adenocarcinoma. So I'm excited to be jointly leading the BEST4 trial with Rebecca Fitzgerald, but the big question in cancer screening, as I see it, is how can we screen for more potentially lethal cancers? Adding a screening program for esophageal cancer is not going to make a dramatic difference to dealing with the problem of cancer mortality. And the problem is that each time we introduce a new screening program, we introduce new false positive results. And if someone took part in, say, 10 screening programs, each with a specificity of 93%, doing one test every 3 years, and if those tests are all independent of each other, then once every 3 years, people would have a 50-50 chance of at least one false positive screening test. That's every 3 years. Over a 30-year period, most people would have several false positive tests. And it seems like the only way we can control the rate of that is to have a single test that is looking for multiple cancers. And it's also the only way that we're ever going to be able to have a screening program for a rare cancer. So if you like, you need to slip that rare cancer in with a screening program that is looking for more common cancers. So I think that to have a pan-cancer screening test or a multi-cancer screening test has to be something that we consider and do a lot of research on. So before discussing multi-cancer early diagnostic testing and screening, I want to consider the potential for polygenic risk scores to overhaul cancer screening. There's a lot of talk about genomic testing coming into the NHS very soon. And the idea would be to predict an individual's risk of getting a particular type of cancer based on inherited low penetrant genetic variants and to tailor the screening to that risk. I like to think of cancer screening as a sieve, or any medical screening, in fact. Traditionally, we only use one sieve, but increasingly, cancer screening relies on a series of sieves. The whole population enters the first sieve, and at the end of the process, a group are identified with cancer. From this perspective, we can think of polygenic risk scores as the first step in this process to find cancer earlier. It is, in that sense, a screening test. And we need to think about it with false positives and false negatives. If it's being used to determine who should get further action, who should get screened, someone who is told they're at low risk and doesn't get screening but nevertheless gets cancer will feel that they had a false negative screen, and potentially someone who is told you should have very intensive screening and never gets cancer would feel that they had had a false positive screen. The average 10-year risk for breast cancer at age 50 is about 2.85%. Currently, the best polygenic risk scores for breast cancer identifies about 10% of women with a 10-year risk of at least 5.3%, and at the other end, about 10% who have a risk of under 1%. Suppose that 1.2% of women have a screen-detectable undiagnosed breast cancer at the age of 50. So it's about 4 years worth of cancer that might be detected. Then among the 10% with the highest risk, the risk that they would find a screen-detected cancer would be about 2.3%. And amongst those with the lowest risk, the 10% with the lowest risk, it would be about 0.4%. The risk of 2.3% is not actually great enough to warrant a 2-week wait referral under NICE guidelines. And the risk of 0.4% is still substantial compared with the risk of other cancers that one might screen for. So for instance, the risk of a prevalent undiagnosed colorectal cancer in a woman aged 60 is probably less than 0.4%. And yet we still have a screening program for women for colorectal cancer. So it is not clear to me that even for breast cancer, which is the one where the polygenic risk scores are perhaps the highest, that this is making sufficient difference to actually say one group should be screened and the other group should not be. By contrast, if we think about a good but not an amazing screening test, and I give 2 examples here, the positive likelihood ratio is likely to be over 50. So if we look here and looking at what would happen if you use these 2 tests in a population where the cancer prevalence was either 1%, 0.5%, or 0.1%, 1 per 1,000 people. And so the first one is with a sensitivity of 80% and a specificity of 96%. And you can see how the positive predictive value is very high if the prevalence is 0.5% or 1%, and the negative predictive value is always very good. But the difference between the risk of cancer if you test positive or negative is hugely different, more than a 50-fold difference. And in the other test, with a low sensitivity, 50%, but a very good specificity, 99%, we're getting similar results. But this time, because of that very high specificity, even when the cancer is rare, the positive predictive value is close to 5%. So I think it's useful to think about changing the order of screening tests. Suppose one has already had a positive screening test, as in a usual form of screening test. Would you ignore that because somebody has a low polygenic risk score? And vice versa. Would you ever think that despite having a negative screening test, somebody needs investigating because they have a high polygenic risk score? So would you ever ignore blood in stool? Or would you ever ignore a lung nodule on a chest CT just because someone's genetic risk was small? So I think having a negative screen is probably always going to be reassuring, no matter what your genetic risk is. And having a positive screen is probably always something you want to look into, even if you have a low genetic risk. So this example is from a paper that is still only published without any typesetting. It's from a group in Spain, and they tested nearly 3,000 individuals who had a positive FIT test. So this is using a threshold of 20, which is done in most of the world. It's 120 in England, 150 in Wales, and 80 in Scotland. But they were going to give colonoscopy to everyone because they had a FIT of above 20. The overall risk of colorectal cancer in those people was 4.25%. And in the 10% with the highest polygenic risk score, it's about 6%, and the 10% with the lowest, it was about 3%. I say about because they only present results in terms of odds ratios, and I think there's almost certainly a typo, which will be corrected, I'm sure, when the paper is typeset. But those differences are not dramatic. If I knew that I had a 3% chance of cancer, I'd probably still want that colonoscopy. If you were going to give it to people with a 4.2.5%. And I think the potential for improving things by using the level of hemoglobin on the FIT test is probably rather greater than from the polygenic risk scores. So one might ask, when should we be using genetics and when should we be using phenotype? And I think the answer is that for long-term risk, we want to use genetics, and for short-term risk, we want to use phenotype. And these two images illustrate that to me. So on the left, this is an army dog. Apparently it costs about $40,000 to train one dog, and you have to start from when they're a puppy. When they're puppies, there's probably not much about that individual dog's behavior that will enable you to decide which is a good dog to train. But their genetics are probably really key. On the other hand, if you're trying to pick the team to compete in the Rugby World Cup, you would rather go on their recent performance than say, oh, but they come from a family of rugby players. And so I think for short term, you want to use the phenotype, and for long term, you want to use the genotype. So given symptoms or results of a screening test, the genetic risk of cancer over a lifetime has very little to add to the risk in terms of an undiagnosed cancer now. So what we can do with genetics is to identify a tiny proportion of the population with extremely high risk of cancer. But as Jeffrey Rose has pointed out, most cancers don't occur in people who have a very high risk of cancer, simply because there are so many more people who have an average risk that focusing on those with a very high risk will have very little impact at the population level. So screening everyone could perhaps reduce the risk of dying of a particular cancer by 25% in those screened. And at the other extreme, if we think of about 0.2% of women who have high penetrance in BRCA1 or BRCA2 mutations, and offering them a prophylactic bilateral mastectomy, one could perhaps reduce their risk of breast cancer by 95% or more. But that would only reduce the risk of dying of breast cancer in the population, even if we rolled it out to all carriers by about 1%. So it's not really going to make a big impact. From the woman's perspective, that prophylactic mastectomy might be a very good idea and have a huge impact. But from the population level, it's really not nearly as effective as mass screening. Of course, you don't have to do one or the other. There's no reason not to do both. And so we need a tailored approach, that a risk-stratified approach to screening and cancer prevention. You offer low-intensity interventions to everyone so that you can have a moderate impact across the whole population. And then additional interventions with greater and greater intensity to smaller and smaller groups as their risk increases. And that indeed is the idea behind risk-stratified screening. But there are various aspects of screening that could be stratified depending on risk. The age of the first screening invitation, the interval between screens, the choice of screening tests, the threshold to referral to another test, particularly if you're using a quantitative screening test, the choice of triage investigation, and the age at last screen. The age of first screening must be determined using external information. But for other aspects of screening, we can take into account the quantitative results of the screening test. We know, for instance, that both the risk of cancer now and the risk of cancer over the next 10 years increases with the level of hemoglobin in a fecal occult blood test. Individuals with no detectable hemoglobin are extremely low risk of getting cancer over the next 10 years. Another issue raised by risk-stratified screening is what to do in order to be equitable. Or more specifically, what metric should we be trying to equalize in order to be fair? I wrote a commentary on this, on equality and equity in screening a few years ago. Groups have proposed using gender-tailored cutoffs in bowel screening based on the amount of hemoglobin in the FIT test. One group proposed using a lower cutoff in women than men in order to equalize the sensitivity of the screening test. Another proposed the opposite, a higher threshold in women in order to equalize the number of missed lesions. Before doing more fancy modeling, we need to debate as a society what it is we want to achieve. What do we mean by equity? What should we be trying to optimize? One possibility is to achieve equity in terms of different metrics for different types of decisions. I might suggest the age of first screening might be set so as to try and equalize the likelihood of having a screen-detected early cancer. In other words, the prevalence of screen-detected occult cancer. The threshold for referral after a screening test might be adjusted to try and equalize the probability of the patient having cancer. So in other words, the PPV of the test. And the time until the next screening invitation should perhaps be based on the risk of an advanced cancer being diagnosed on or before the next screen. And so on. We can think of different ways of stratifying screening. We need to be intelligent in how we do that. It does not make sense to stratify only on age-specific risk of cancer without thinking about how the sensitivity of the test might vary or the fitness of the individual to manage surgery. So for instance, in breast screening, mammography is far less sensitive, or the lead time that you get from the low risk after a negative mammogram is much shorter in women in their early 40s than in women in their 50s or 60s. And so it's not just about the risk, it's about the benefit of a screen that we should be thinking. As a corollary, if we plan to vary screening interval based on polygenic risk scores, it should be the polygenic risk of having a cancer with a shorter or longer sojourn time. If an individual is at increased risk of a grade 3 or a rapidly progressing cancer, then perhaps they should be screened more frequently than someone who is at low risk of a rapidly progressing cancer, even if that other individual is at greater risk of cancer per se. Because the screening interval should be to do with the natural history and the progression of cancer. To risk stratify screening intervals, we need to do GWAS studies to distinguish between those who get advanced cancers despite previous screening and those who are only diagnosed with screen detected or interval early stage cancers. I believe the greatest potential of risk stratified screening comes once one has the screening test result, and depends on having a menu of options for managing screening program participants. Traditionally, you either screen positive and get referred for a further investigation, or you screen negative and return to routine screening. But what about an intermediate risk group who would receive some sort of triage, or a very low risk group who could have extended screening intervals? At the risk of overcomplicating screening, could we have a whole menu of options following a screening test? To understand why this is important, consider a typical ROC curve here. Many scientists would look at this and choose a point in the top left-hand corner where the sensitivity and specificity are about equal. A screening expert might pick a threshold such as the green diamond in the bottom left with a very high specificity. Here, the positive predictive value is likely to be very high, but the sensitivity is only about 25%. Clinicians might be tempted to pick a threshold such as the red diamond in the top right, with a very high sensitivity, even if the specificity is quite poor. At this cutoff, the test would have an excellent negative predictive value. In other words, you could rule out cancer. But why not use both thresholds? Why not use both the green and the red thresholds? Those with a very high level of the test would be considered positive and would be referred to diagnostic investigation. Those with a very low level would get no further screening, perhaps, ever, particularly if the test is informative not only about cancer now, but also cancer in the future. And intermediate values might lead to periodic screening. The goal of such a risk-stratified bowel screening program is fourfold. Can we screen overall less often in the population? More importantly, can we prevent more colorectal cancer deaths? And can we prevent more cases of colorectal cancer by finding adenomas, advanced adenomas, and treating them, removing them? Can we prevent cancers? And can we do it with having a minimal impact on the need for colonoscopy? We have a severe limit in this country on our capacity to do colonoscopy. And so we need to be able to improve the screening program without dramatically increasing the demand for colonoscopy. Can this be done? I think so. The answer, I don't think, will come from polygenic risk scores, but rather using the level of hemoglobin in the FIT test. These results are from the NHS FIT pilot, which was done a few years ago, published in 2017. And you can see as the threshold is lowered, moving from right to left on the table, the proportion of the population above the threshold increases, of course, but so does the number of cancers and the advanced adenomas detected. Compared to the old guaiac FOB test on the right, using a threshold of 40 micrograms of hemoglobin per gram of feces, would mean that 3 times as many people would be referred, but one would detect twice as many cancers and 4 times as many advanced adenomas. The problem is that we don't have the capacity for doing 3 times as much colonoscopy, and nor do we seem to be able to increase that capacity. So this would be one such menu, starting from the bottom with a very high threshold. So if you have over 150 micrograms of hemoglobin per gram of feces, you might be referred to colonoscopy. Somewhat controversially, I would like to reintroduce flexible sigmoidoscopy, not as a screening tool, as was done previously, but as a triage tool in those with intermediate level. People say, how on earth can you only look at half the colon when someone is screened positive? But I would counter that currently we're telling people who have hemoglobin in this level that they've had a negative test, and so we don't look at any of the colon. Moving on to those with the moderate levels, 20-40, between 20 and 40 would have an early recall. If the level is still elevated, they would receive endoscopy. And if it decreases, they would be rescreened at 1 year. If you really don't want to use flexible sigmoidoscopy, you could use CT colonoscopy, or you could just do the early recall for everyone instead of the flexible sigmoidoscopy, and refer to colonoscopy, perhaps if the sum of the 2 tests exceeds 160, say, and do a third test if it's still over 20, but the sum is below 160. Very low or undetectable levels would lead to extended screening intervals. I think it would be safe if there's no detectable hemoglobin to offer the next screen in 5 years' time. My back of the envelope calculation suggests that this really is a win-win solution to bowel screening. With fewer screens over a 10-year period, increasing the average screening interval to about 2.5 years instead of 2 years, similar rates of colonoscopy as we have at the moment, but the need for a slightly greater number of individuals to have some sort of flexible sigmoidoscopy, CT colonoscopy, or possibly pushing more into actual colonoscopy, depending on what you want to do there. And then the cancer detection rate would be about twice what it is currently, and the number of advanced adenomas detected, hopefully removed, would increase about 3-fold compared to what they are. So with very little additional resource, particularly if you think that 100% of people were being offered flexible sigmoidoscopy once in their lifetime, at least in theory previously, one would be at least doubling the benefit of the screening program and possibly more. But I think it's imperative to do those things. But that's promising advances for esophageal cancer, colorectal cancer, possibly prostate cancer. But what are we going to do about the vast majority of cancers that are lethal? We need some sort of multi-cancer early detection test. There are now blood tests that look for cell-free DNA that can detect cancer. What is their potential in screening? What might be the harm of a false positive MSED test? Problem is that if we don't know where to look for the cancer, how much investigation would you do before deciding that it was a false positive test? How many people would have unnecessary biopsies or be exposed to radiation? If you had this, would it replace existing screening programs? And if not, how would you combine it? One thing seems clear: it is difficult to find a role for PRS in site-specific screening. It is even harder to argue for its use using a pan-cancer screening test. Extremely few people are at substantially low or high genetic risk of all cancers combined. So if we have a really good MSED screening program, the role of PRS in stratifying that screening is probably going to disappear. So we'd like an MSED test to detect potentially lethal cancers, especially ones for which there is no existing screening program, and we would like it to avoid detecting indolent cancers. And for screening, we would like to have a very high specificity in order to be able to have a high positive predictive value. If you test positive, there is a good chance you've got cancer. And as an aside, if you wanted to use the test in symptomatic people, people coming through 2-week waits, you need a very high sensitivity because you want to be able to rule out cancer in that group. So what you want from those tests are quite different. Gallery is the name of Grail's MSED test. It's based on technology that's used in antenatal screening today. Tumors and, for that matter, fetuses shed nucleic acid into the host's blood. Those nucleic acids differ from those that are normally present in the blood. The Gallery test looks at patterns in the methylation of cell-free DNA isolated from peripheral whole blood. It first looks for a pattern of cancer. If that pattern is found, the test is positive, and it then looks for a pattern to suggest where the cancer might be. The test was developed and analyzed in 3 large case control studies called Circulating Cell-Free Genome Atlas study. The first was a discovery phase. Grail found that the whole genome methylation outperformed targeted mutations and whole genome chromosomal alterations in distinguishing between the blood from patients with cancer and from volunteers without cancer. The second study then used the winning type of this assay from the first, methylation, but instead of doing whole genome methylation, they looked at patterns in about 100,000 targeted regions and used an AI algorithm in order to best distinguish the patterns associated with cancer from the patterns that were non-cancer. And then if there was a cancer pattern present, they then used a second AI algorithm to predict the site of the cancer. And this was done in some 2,500 cancers, including 50 different types of cancer and over 40,000 blood samples from people without cancer. And finally, there was a validation study called CCGA3, which took the assay and the classifier developed in the training study and applied it to 2,800 cancers and 1,250 controls. Overall, that test had a specificity of 99.5% in the validation sample. In other words, just 6 of those 1,254 control samples tested positive, and a sensitivity to all cancers across 50 different types of about 51%. But that sensitivity varied by stage. As one might have predicted, the more advanced the cancer, the better the sensitivity. And you can see if you look for all cancers, the sensitivity was only 17% for stage 1 cancer, but 90% for stage 4 cancers. Whereas in a pre-specified list of 12 cancers, which I put down at the bottom there, the sensitivity was still not great in stage 1, but became pretty good, 70% in stage 2, and it was still very high in stage 3 and 4. And on the right, I'm sure you can't read the different cancers, but it's showing the sensitivity for different cancer sites. And in general, the sites with the very poor sensitivity are sites such as thyroid, prostate, and breast with fairly indolent cancers. And the cancers on the right with very high sensitivity, or the good sensitivities, are the more aggressive cancers, things like pancreas, lung, and ovary. So the implications of the sensitivity and specificity observed is that this will be a pretty good screening test. So if you had an asymptomatic population where the cancer prevalence is, say, 0.8%, the positive predictive value of this test would be 45%. And the chance of cancer in people who test negative would be about half of what it was, so about 0.4%. But that's why you can see why it's not very useful in a symptomatic setting. If 8% of the people you're testing have cancer, then that would only be reduced to 4% in those who test negative. even though those who test positive are almost certain to have cancer. So Grail also did a prospective study called Pathfinder. This was done in 2 parts, one using the test before it was named Gallery, and a second with the new version of the test, which was deliberately made more specific. In the first 6,500 people who were tested and then evaluated for cancer if they tested positive, 1.4% tested positive, and amongst those in whom we know the results of the diagnosis already, the PPV was 45%. And in the new test, which is more specific and a slightly lower risk population that were tested, 0.9% tested positive. And amongst those that we know what's going on, the positive predictive value was 63%. Across the 2 studies, the first predicted site was correct about 85 to 90% of the time, and the first or second site found the cancer about 95% of the time. But the bad news, or possibly slightly bad news, is that there were roughly equal numbers of cancers at stage 1, stage 2, stage 3, and stage 4 amongst those screen-detected cancers. If we're trying to say we want to make 3/4 or more of cancers to be diagnosed at stage 1 or 2, that's not great. But I'm reasonably optimistic that this is because we're testing a group in whom there was a lot of prevalent advanced cancer. And when we come to doing repeat screening at 1 year and at 2 years, most of those cancers, screen-detected cancers, will be early stage cancers because we will have removed the pool of advanced cancers, if you want. I'm convinced that these results are good enough to justify a large trial, and so with the NHS, and that screening trial is happening now. So Austin Bradford Hill is known as one of the pioneers of randomized controlled trials, so I could hardly give a talk about NH Gallery in a Bradford Hill Seminar if it wasn't a randomized trial. But I think there's a big question about how that trial should be designed, and it's something that I thought about a lot. And the first question that we had to address was whether it should be a study of efficacy, an explanatory trial, or of effectiveness, a pragmatic trial. And just to remind you, efficacy is the effect of the intervention under ideal conditions, and effectiveness is what might happen in the real world. You might think of efficacy as the impact of actually screening someone, whereas effectiveness is what happens if you offer screening to someone. And I would argue that there's no point in trying to show effectiveness until you have established efficacy. But how can you study efficacy in a randomized controlled trial of screening? One way is to try and ensure that everyone randomized for screening actually gets a screening test. And one can do that by recruiting and consenting individuals, drawing blood, and only then randomizing them. And that way, half of the participants will have their blood tested, and half of it will have it stored but not tested. What is more, we can preserve the blinding of most participants if we only unblind those who test positive. So we don't tell individuals who test negative that they've tested negative. Instead, they get the same letter as controls, thanking them for participating in the trial and confirming that they are not awaiting a further test result, so that they're not going to be getting a positive test result. Why is it so important that we do an efficacy trial before an effectiveness trial? Why is it so important that we get a very high compliance or uptake of screening? And this graph plots the sample size on a log scale needed for 90% power against the proportion in the screening arm who are screened. And with a 100% screening uptake in the bottom right, we need 140,000 people randomized to have sufficient power. But if screening uptake is just 15%, which is similar to the participation rate of everyone invited for the trial in the NHS Gallery trial, we'd need 6 million people. So I find it challenging enough to do a trial randomizing 140,000 people. 6 million would just be a nightmare. So what should be the primary endpoint of a trial like this? Well, somewhat controversially, we're using a reduction in advanced stage cancer. So there should be fewer stage 3 and stage 4 cancers over a 3-year period or 3 to 4 year period. And that's the primary endpoint of the trial. We're doing this because we believe it's a robust surrogate for cancer-specific mortality and because it provides a readout 2 to 3 years earlier. This is important because if screening using the Gallery test could prevent 20% of all cancer deaths, we would not wish to delay the establishment of such a screening program unnecessarily. Additionally, I think it's a clinically meaningful endpoint because I would rather have a stage 2 cancer and not die from it than to have a stage 4 cancer and be cured of it, because the side effects of the cancer and of the treatment are so much greater. So even if it would make no difference to mortality, I would still prefer not to have an advanced cancer. And it's worth emphasizing that we will still be looking at, the proportion of cancers, advanced cancers, a reduction in that. So we're not looking at the proportion of all cancers that are advanced, because that might be achieved. We could get a smaller proportion simply by getting more early cancers. So if we were overdiagnosing early cancers, we'd see that a smaller proportion of cancers are advanced. We actually want to see an absolute reduction in advanced cancers. But we will also look at cancer-specific mortality. It's just that it's going to be 2 or 3 years later. But we also need to do that rather cleverly. And because we have taken blood from everyone, and we will continue to take blood from both the intervention arm and the control arm, we can improve the power by retrospectively testing the stored samples from controls who die of cancer. And the idea is that screening will have no impact on cancer mortality in those who test negative, but a positive screening test will in many cases lead to earlier diagnosis of cancer. And it's hoped that by initiating treatment earlier, we will reduce mortality. And so we can do that, and we can use a similar thing to look at overdiagnosis. And just to show what happens here in summary, if we did a simple pragmatic trial, we would need to randomize 6 million people to look at advanced cancer endpoint. Whereas once we randomize only at the clinic, we can reduce that to 140,000. And to look at cancer mortality, if we just did it on the simple comparing the 2 arms, everyone in the 2 arms, we'd need 300,000 people. But by retrospectively looking only at people who both die of cancer and had a positive test, we can reduce the number to 140,000 again. So NHS England have a long-term plan that 75% of cancers should be diagnosed early at early stage, so stages 1 or 2 by 2028. And this trial is key to that plan. So what are my recommendations and conclusions? Very quickly, in terms of polygenic risk screening, I think from a public health perspective, screening is most effective when everyone is included. And I think that if you're going to use polygenic risk scores, you need to make sure that you have the risk of the right thing for the right way, for a particular way of modifying screening. In terms of risk stratification, I think that it's inevitable that some forms of risk stratification will become the norm. Complicated changes must be justified in terms of a worthwhile improvement. It's clear that you can improve screening and make it slightly more efficient, but much of the modeling has showed that the magnitude of the improvement will be quite minimal, and the upheaval to the screening program may not make it worthwhile. But we are already using targeted screening for lung cancer based on exposures, smoking, asbestos, for esophageal cancer in the BEST4 trial based on chronic symptoms, and in breast and bowel screening for people with very high penetrance mutations. I think MSED tests are the future of screening. It may not be the Gallery test, and it may not be this trial, but I think within 15 years, it is very likely that there will be some sort of multi-cancer early detection test used in screening. But it's really important to analyze those tests rigorously in a randomized controlled trial, no matter how good the cross-sectional results seem to be. And we need to consider efficient designs, because we just can't afford to do trials in 6 million people or to wait 15 years for the results. Thank you very much.